I am David Ballard, Senior Vice President and Chief Quality Officer of Baylor Healthcare System, a healthcare delivery organization with over 15 hospitals and more than 20,000 employees providing care across North Texas. I also serve as Health Policy Section Editor for the Mayo Clinic Proceedings. In this issue of the Mayo Clinic Proceedings, we address ways that U.S. healthcare delivery organizations are responding to the challenge of reducing healthcare costs while improving healthcare quality. Specifically, we examine this challenge through the lens of the accountable care organization component of the final rule for the Medicare Shared Savings Program under the Patient Protection and Affordable Care Act. Donald Berwick, the former administrator for the Centers for Medicare and Medicaid Services, who launched its Accountable Care Organization program, defined ACOs as voluntary groups of physicians, hospitals, and other healthcare providers that are willing to assume responsibility for the care of a clearly defined population of Medicare beneficiaries attributed to them on the basis of patients' use of primary care services. As described by Dr. Berwick, the benefits such organizations receive in exchange for this assumption of risk is that if an accountable care organization succeeds in delivering both high-quality care or improving care and reducing the cost of that care below what would otherwise have been expected, it will share in the savings it achieves for Medicare. To date, CMS has defined two mechanisms for ACOs, the Pioneer Program and the Shared Savings Program. The Pioneer model allows the ACO to move more rapidly from a shared savings payment model to a population-based payment model and generally applies a higher level of shared savings and risk. Currently, there are 32 Pioneer ACOs, 27 Shared Savings ACOs initiated in early 2012, and an additional 89 Shared Savings ACOs just announced by CMS in July 2012. To shed more light on how healthcare delivery organizations have evaluated these ACO opportunities and have either engaged them or sought alternatives, I have interviewed several regional healthcare system leaders representing the three categories of response: adoption of the Pioneer ACO model, adoption of the shared savings model, and adoption of neither model. I'd like to introduce Dr. David Shokan, president of the Morristown Medical Center in Morristown, New Jersey. He's also the CEO of the Accountable Care Organization associated with the Atlantic Health System, which is part of the Medicare Shared Savings Program. So, David, why did your organization decide to participate in the Medicare Shared Savings Program?
Well, we really started the Accountable Care Organization because our system of healthcare in New Jersey was so fragmented. In New Jersey, there aren't many large integrated systems of care, but rather we have independent hospitals, physicians, long-term care facilities, and we're not organized to approach population health strategies in the right way. So with that type of fragmentation, it makes it difficult to implement care strategies that reduce the cost of care and improve quality. So let me just give you some examples. The average New Jersey Medicare patient sees 48 physician visits each year, where the average in the country is just 30. The number of patients in New Jersey that see more than 10 different physicians is 46% compared to just 30% in other places in the country. And so it's that type of fragmentation of care and opportunity to improve care that led us towards the Medicare Shared Savings Program and the Accountable Care Organization.
So, David, could you share with us some of the specifics of your organizational approach to the Shared Savings ACO opportunity?
Yeah, the Atlantic Accountable Care Organization includes 6 hospitals and 1,400 physicians. And in April of this past year of 2012, the Atlantic Accountable Care Organization was awarded a Medicare Shared Savings contract. So we were one of 27 ACOs that began operating this past April. Actually, we're the second largest in the country with more than 50,000 Medicare patients. And the way that we're organized is into regional pods by geography. So we have different counties in New Jersey, 4 specific distinct regions that have physician governance. So there are physicians who chair the governing board, who chair our utilization committees, who chair our quality committees and our care coordination committees. And together they organize approaches among how hospitals work together, primary care physicians, specialists, long-term care facilities, home care facilities, and use clinical navigators to actually help patients with chronic illness and help patients that are just with multiple disease categories so they become high utilizers of care. It helps them coordinate the care in these different regions of New Jersey.
So, David, you've shared with us some of the overarching things you'll be doing to improve quality and reduce costs through your shared savings ACO. But let's try to move on to some specific clinical scenarios. So how do you see things changing for physicians and other clinicians related to your accountable care organization strategy?
Well, I think that there are 2 general distinctions in care redesign that we're trying to do in the accountable care organization. The first has to do with patients with chronic illness, those patients that require team approaches towards really managing their chronic illness in the most efficient and highest quality way. We've developed centers of excellence approaches. For example, we have a program called Cardiac Success, which is for congestive heart failure patients. And what this is primary care doctors, specialists in heart disease, and advanced practice nurses who work off of protocols of care. And what we have found as a result is we have achieved a 4 to 6% all-cause 30-day readmission rate for patients with congestive heart failure in this program, compared to national averages of 25 to 30%. So we've been able to demonstrate with chronic illness, by getting the right type of protocols and team-based approaches to care, that we can better manage chronic illness. And we have developed 16 of these centers of excellence programs for chronic illness. The second approach beyond chronic illness are really the multiple comorbidities, those patients that require high resource intensive utilization of care. Patients are constantly sick and going back and forth to the hospital. And here we've employed traditional care management strategies where case managers who are nurse trained work directly with the primary care physicians and the specialists to see what additional resources we can do to bring to those physicians to help decrease the utilization and resource intensity of these patients. So I think as a doctor, you're seeing 2 new approaches to care. One is having provider-based care managers working with you on high-resource patients, and you're seeing now centers of excellence programs made available to you for patients with chronic illness.
So, David, to bring it down maybe to some specific clinical scenarios, where do you think your ACO strategy might reduce care on the margin? Are there particular areas of what might be referred to as clinically unnecessary care where you think your progress in those areas might be accelerated through your ACO?
Yeah, I do believe so. I think that they come in multiple areas. I think that there are several areas where accountable care organizations are looking first to focus their efforts. Number one is access to care. When patients can't get access to the right specialists or even back to their primary care physicians, they use other highly resource-intensive facilities like emergency rooms and accessing facilities that, frankly, are at higher levels of acuity than what they need. So one thing we're doing is getting people comfortable with going to their primary care physicians, using advanced practice nurses where possible, and making access to care just easier and more accessible. The second area is that we are using new technologies to help patients and help physicians care in more efficient settings. So we are using more telemonitoring and using other types of communication with patients in home settings rather than in the hospital setting. And third is we are using best practices through our protocols and through our centers of excellence programs to make sure that there aren't the gaps in care or the omissions in best practices that do lead to patients getting readmitted to hospitals or getting unnecessary procedures or tests. And if we follow these best practice approaches, we do believe that we can make an impact. And the last area I should mention is medication compliance. We do know that patients who do not comply with the appropriate medication regimens do have higher rates of utilization of high-intensity places like emergency rooms and hospitals.
So, David, will anything change for your ACO related to the recent Supreme Court ruling regarding the Accountable Care Act?
Well, I think that the ACO was anticipated to be part of healthcare reform. So I think that with the Supreme Court ruling, it confirms that the country is heading in this direction, that this is a strategy of continue to have improved access, but to find ways to lower the cost and to do population health strategies. So I think that if there had been a reversal in the Supreme Court, the ACO strategy may have been at risk, but now confirmation that this is going to continue forward. And I do think that the ACO itself is just really one of a number of strategies that will help providers in particular get more engaged in population health strategies.
So, David, we greatly appreciate your sharing your insights with us regarding ACOs and your particular approach through the Atlantic Health Organization. Is there anything else you'd like to share with us about ACOs that we haven't discussed?
Well, I do hope that our readers and listeners around the country will take a look at this strategy, because it is a way for hospitals and physicians and other community resources to begin to start coordinating and collaborating together.
Thank you very much, David, for your insights, and we look forward to observing your progress with your Shared Savings Program, ACO, and other ACO programs linked to the Atlantic Health System.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.